Welcome to The Explainer. So glad you're joining us today because we are about to unpack one of the absolute highest stakes medical emergencies in all of human pathology. We're talking about a condition where literally every single second counts and the line between life and death is razor thin. We are talking about aortic dissection.
So think about this. What happens when the human body's largest artery begins to tear from the inside out? This isn't some slow-moving chronic illness that takes years to develop. No, it is an explosive, catastrophic event. I want you to imagine a ticking clock, literally counting down the minutes where your body's main supply line is rapidly failing. It's a literal race against time, and understanding exactly how this happens it's absolutely fascinating.
Section 1, Anatomy of a Tear, inside the aorta.
Okay, let's dive into this and start unpacking the literal physical damage going on here. To really grasp the sheer urgency of this, we need to look closely, microscopically closely, at the physical damage. An aortic dissection is the sudden tearing of the tunica intima of a weakened arterial wall. Now, a lot of people think of this like a burst pipe, but actually, scratch that, it's way more complex than just a burst pipe. Your aorta isn't just a simple hollow tube. It's made up of distinct layers. The tunica intima is that very innermost lining, and when this condition strikes, that inner lining rips. What we're looking at is a structural delamination of the vessel wall itself. The layers of the artery are quite literally peeling apart.
And that brings us to the chronological sequence of destruction. It's a very specific chain reaction. Step 1, the initial intimal tear occurs. Boom. Then step 2 is where the chaos really begins. High-pressure blood from the main channel, the lumen, violently enters the middle layer of the artery wall, which is called the tunica media. Finally, in step 3, that blood dissects. It forces its way along a laminar plane, basically the natural grain of the tissue, right inside the outer media. It acts exactly like a wedge, relentlessly driving the layers apart until, eventually, well, if the clock runs out, it completely ruptures.
Section 2, Types and Triggers. Who is at risk? So let's shift gears for a second to figure out where exactly this happens in the body and who is most vulnerable to this catastrophic event.
Anatomically speaking, dissections are categorized entirely by where they strike, and we've got two main culprits here. A type A dissection happens in the ascending aorta, that's just after the aortic valve. A type B dissection, on the other hand, occurs a bit further downstream in the descending thoracic aorta, just past the left subclavian artery. And you really need to keep this visual anatomical difference in mind, because the location dictates absolutely everything about how lethal this is and how we have to treat it.
Now check out this massive statistical disparity. 90% of these cases are type A, only 10% are type B. To put that into perspective, the vast, overwhelming majority of these traumatic tears are happening right at the exit of the heart. That is the exact place where blood pressure is at its absolute highest, just battering against that weakened arterial wall.
So why does the wall weaken in the first place? Well, hypertension, high blood pressure, is a massive catalyst here. It provides the sheer, brutal force needed to rip the tissue. But there are also key underlying conditions. For instance, Marfan syndrome, a connective tissue disorder, makes a type A tear significantly more likely. Other triggers include a bicuspid aortic valve, which is having 2 flaps instead of the usual 3, and correctation, or narrowing of the aorta. And pregnancy, interestingly enough, is also strongly associated with an increased risk for both types.
Section 3, the double barrel, 2 functioning lumens. Honestly, this is one of the most visually striking and, frankly, terrifying concepts we're going to cover.
The double-barreled aorta. Now, what's really interesting about this slide is just that incredible medical phrase. It sounds like something straight out of a sci-fi movie, right? But it is a very real, very dangerous phenomenon. Let's look at exactly what this implies.
The morphology behind this is just wild. In about 90% of cases, the initial intimal tear happens within 10 centimeters of the aortic valve. But the blood doesn't always just sit there trapped. Sometimes it literally tunnels down the wall of the artery and then tears back into the main vessel further downstream. So the blood enters a proximal tear and exits a distal tear. And what does this do? It essentially creates a rogue, false second channel within the artery wall itself, 2 functioning lumens, a double-barreled aorta. And it is absolutely crucial to note that, unlike an aortic aneurysm, this specific dissection doesn't usually cause a marked balloon-like dilation of the aorta. It's a hidden internal tear.
Section 4, the warning signs, spotting the crisis. The pace of this condition is incredibly fast, so recognizing the signs quickly is everything.
The way an aortic dissection presents in a patient is brutal. Sudden, severe, persistent chest pain that comes on instantly. It's nearly always in the front, but often radiates right through to the back, eventually progressing down to the abdomen and the hip. But here is the truly terrifying part. It looks almost exactly like a common heart attack or myocardial infarction. We actually call a heart attack the imposter in this scenario because if a doctor misdiagnoses an aortic dissection as a standard heart attack and decides to give the patient blood thinners, that can literally be a fatal mistake.
And sadly, that chest pain is just the beginning of the cascade. As the tear moves down the aorta, it acts like a devastating avalanche, cutting off blood supply to various branch arteries. Let's walk through this systemic chaos. If it occludes the intercostal and lumbar arteries, the patient suffers paraplegia. If it cuts off the mesenteric artery, you get an acute abdomen. If the arteries arising from the aortic arch get blocked, it leads to syncope, meaning fainting, or hemiplegia, which is paralysis on one side of the body. You can also see rapid renal failure and leg ischemia. It is total systemic shutdown. Because it's such a convincing imposter for a heart attack, clinicians have to rely on very specific, urgent clinical red flags. First, unless the aorta has completely ruptured, the patient is almost invariably hypertensive. That high blood pressure is literally physically driving the tear further down the artery as they lie there. Second, you might spot an asymmetry in the pulses, so the pulse in the left arm might feel completely different from the right, or the carotid, or the femoral. Finally, if the dissection is close to the aortic valve, it can cause immediate aortic regurgitation.
But, we have to address the ultimate, somber reality of this ticking clock. If intervention doesn't happen in time, the outer wall simply gives way. Lethal rupture. Death usually results from the aorta rupturing entirely into the pericardial sac surrounding the heart, or pouring into the pleural space of the lungs. Alternatively, that severe acute aortic regurgitation can cause rapid, terminal heart failure.
Section 5. Solving the mystery, the diagnostic toolkit. Let's move to and see how this builds into the critical detective work phase, where we try to catch the imposter.
So how exactly do we catch it? Well, an ECG might show left ventricular hypertrophy thanks to that baseline hypertension we talked about. Interestingly, you might even see inferior wall abnormalities if the tear actually involves the opening of the right coronary artery. A chest X-ray is a classic tool here, often revealing a widened superior mediastinum, or fluid effusions. But, to be absolutely certain, doctors have to confirm the dissection rapidly using advanced imaging. We're talking a CT scan, MRI, angiography, or a transesophageal echo. And once it is confirmed, the location dictates the reaction, and the contrast here is stark. A type A dissection, remember that's the 90% majority, located right at the ascending aorta near the heart, requires emergency surgical repair. The patient must go under the knife immediately. There is no other option. A type B dissection, however, descending further down the chest, is fundamentally different. It can actually often be managed with medical treatment alone. So what does that pharmacological medical management look like? The absolute priority is to lower the pressure, to stop that wedge of blood from propagating the tear any further. Doctors will aggressively treat the hypertension using beta blockers and/or sodium nitroprusside to rapidly bring the blood pressure down. For a type B dissection, surgery is held strictly in reserve. It's only required if there is an actual or impending rupture of the aorta.
We started with a ticking clock, and we're going to end with a challenge. Can you distinguish the ultimate medical imposter from a common heart attack before time runs out? Understanding these subtle differences, the triggers, and the anatomy of the tear. This isn't just medical trivia. It is the exact knowledge required to stop the clock and save a life. Thank you so much for joining me for this explainer. Keep asking questions, and I'll see you next time.